So let us continue looking at drugs used in the treatment of asthma. And basically, there are two. We are not treating asthma as a chronic condition, but we treat an asthmatic attack. So these drugs are two. One, we have bronchodilators. Why should we need bronchodilators? Because they are airway constriction during an asthmatic attack. And this airway constriction is the one which brings about difficulty in breathing. Then another group of drugs, we need anti-inflammatory drugs, like we have said above, that the process of an asthmatic attack involves a process of inflammation. So we should be able to have drugs which will reduce on the inflammatory rate. So when we talk of bronchodilators, they can be grouped into two. Those are the beta agonist, and these promote bronchodilation by stimulating beta-2 receptors in the broncho smooth muscles. We have said we need bronchodilators, and one of the bronchodilators are beta agonists. And these beta agonists, they promote the bronchodilation by promoting the beta-2 receptors in the broncho smooth muscles. A common example we have is the salbutamol. These patients usually use as tablets or inhalers or in in nebulization. Then other groups of drugs are xanthines. These act as relaxers of the smooth muscles. And this one, the commonest example we have is aminophylline. So at the end of the day, all of these are bronchodilators, but maybe they have different mechanisms of action. Whereas salbutamol works by stimulating beta-2 receptors, xanthines act by relaxing smooth muscles. Then we have said that we also need anti-inflammatory drugs to reduce on the inflammatory rate. And some of these are corticosteroids. These reduce the bronchomucosal inflammation and bronchohyperactivity. They are recommended in patients not responding to beta-2 agonist, e.g., an example is beclomethasone, hydrocortisone, prednisolone, and dexamethasone. So these corticosteroids are said to be recommended in patients who are not responding to maybe the salbutamols. Then we have other drugs called the mast cell stabilizers. Remember, the mast cells are one of the cells which participate in the inflammatory process, or the sensitivity, and then lead to the inflammatory process. So some of these anti-inflammatory drugs can be mast cell stabilizers. So this is the general supportive management of a patient in an asthmatic attack. Depending on the cause, antibiotics may be needed. Why? Because some of the causes of the trigger is infection of the throat, things like cough, cold, and flu. So if there is any infection of the respiratory tract, it should be capped up with antibiotics, preferably penicillins. Those are the amoxicillin, ampiclox, cloxacillin. Even we can also use other drugs like ceftriaxone, etc. If the upper respiratory tract system is very bad. Then positioning, that is obvious as one of the nursing actions in patients with difficulties in breathing. Then we give humidified oxygen while there is bronchial airway constriction. So this patient is having a problem to do what? To have oxygen in. So we can give oxygen. And then we are saying if this patient is tachypneic, we can maintain this patient as nil per os. Tachypneic, the patient is breathing very fast, and if you get anything orally, it means this oral food or oral drink you have given, it can divert and go into the airway and cause more problem. So by the time this patient is tachypneic, we must keep the patient nil per os. Then we allow adequate sleep. We administer intravenous fluids to maintain adequate hydration, monitoring input and output. These are key factors. So this is the general management of any patient who may be asthmatic. So now let us look at a pregnant mother. So this is a mother who has been living with the condition and is knowing it. So what does it mean that during antenatal history taking we shall ask of chronic conditions, or which will the mother tell us that I'm asthmatic, I have my nebulizer if I get this, and this is how worse my asthma is, etc. So we don't think that this mother is going to get asthma during pregnancy. Has been a condition she knows, and the condition may be which has been well managed. So if we have such a client as midwives, we are supposed to do what we call pre-conception care. And usually these are talks, health awareness. We talk to groups of people who are in reproductive age. Sometimes when we talk about health education talk, we always think about a pregnant mother. But what have we done before this mother becomes pregnant in order to have a safe pregnancy, labor, and puerperium? So in most cases, planning of delivery, planning of pregnancy is very essential, especially in patients with chronic conditions. So we are saying that during preconception, women planning to become pregnant are advised to optimize asthma control before conception. Preconception counseling can address medication safety and reinforce the importance of maintaining treatment to reduce the risk of exacerbations during pregnancy. So as we have said that some of these patients know the triggers, what triggers their condition. They know how to use their inhalers. They know they have been living with their conditions for quite a long time. So when they could wish to become pregnant, maybe we are counseling young couples who are just married. We talk about them avoiding the triggers. And avoiding these triggers, it means they will maintain treatment and reduce the risk of becoming in an asthmatic attack. If the patient has been smoking, we strongly encourage cessation, as smoking can worsen asthma and increase the risk of pregnancy complications. So, prenatal care, regular monitoring. Asthma should be closely monitored throughout pregnancy with frequent follow-ups to assess lung function, symptom control, and medication use. Spirometry and peak flow monitoring can help to evaluate the respiratory status. So as this mother is pregnant and coming to antenatal, we should closely monitor her and give her frequent follow-ups, which may be different from any other mother without a chronic condition. And by doing this, our rationale is to control the symptoms, is to see whether the medications this mother is having are of use, and continuously evaluating her respiratory status. So, trigger avoidance: identify and avoid asthma triggers as much as possible. Influenza vaccination may also be recommended. Patient education: provide education on recognizing early symptoms of exacerbations and emphasize the importance of adhering to prescribed drugs. These patients should be made very aware of their condition when they are pregnant. They should be in position to know the signs, early signs, when they are having triggers. And we emphasize the importance of treatment adhesion. Here, most of these patients are moving in with their inhalers. So, they are taught that in such conditions, an inhaler should be in your bag always, in order, like you feel a very little sign, you puff, you make puffs in order to prevent an attack. Otherwise, other people may keep quiet, they left inhalers away from them, and they think they'll be fine. And at the end of the day, you shall see them collapsing. So, patient education is very important, such that they know the nature of their condition and they will participate in their own care. Then we have medication management, that is inhaled corticosteroids. This remains the mainstay for controlling persistent asthma during pregnancy. Here, the most drug is salbutamol. It is often preferred, and it is preferred, but most inhaled steroids can be continued. Short-acting beta agonist, that is salbutamol. It is used to rescue medication for acute symptoms and exacerbation, and is considered safe during pregnancy. So you also remember that some drugs may not be safe during pregnancy, but for salbutamol, it is considered safe during pregnancy. Then there are some long-acting beta agonists, because we said we need some beta agonists, and salbutamol is a beta agonist. It can be used in combination with ICS. ICS is the above, that is ICS, these are inhaled corticosteroids. Corticosteroids, I said, the preferred one is dexamethasone, prednisolone, etc. So, these long-acting beta agonists can as well be used with the beta agonist in order to control the attacks. Then, we also talk to this mother to avoid systematic corticosteroids if possible. While oral or IV corticosteroids like prednisolone are sometimes necessary for severe expiration, they are generally reserved for short-term use to manage acute asthma attacks due to their potential risks. So, when this mother is pregnant, or even though is not pregnant, we should prefer oral corticosteroids over IV corticosteroids, because corticosteroids are having a very high they have very high potential risks like gestational diabetes and preterm labor. So let us, like we said that in the beginning, we educate these patients. So as we educate them to prevent as much as possible the triggers to their condition, they should quickly adapt to oral corticosteroids better than IV corticosteroids. So what happens when this mother is having an acute trigger or an attack, what we call an attack? We are saying that prompt and aggressive treatment of asthma is crucial to avoid maternal hypoxia, which could even harm the fetus. Remember, if this mother is short of oxygen, even the fetus is short of oxygen. So prompt management should be done. If you are near, we can give oxygen. We can give oxygen, and we should maintain the saturation at above 95%. Then we should be in position to give the nebulized bronchodilators. And by this level, I think we should be able to know how to administer salbutamol using a nebulizer. Then this is the time we shall need the systemic corticosteroids, and this may be required if this patient is in severe condition and this patient is not responding to inhaled medication. And hospitalization. Severe expirations should be managed in hospital setting with close monitoring of maternal and fetal well-being. And they are saying in rare cases, these patients may not need, in rare cases, they may need ICU. But if they are managed well, these patients may not progress to ICU. Then, because this mother is pregnant, we cannot forget to monitor fetal growth or fetal well-being. So, when this mother is fair, we can do an ultrasound surveillance with women with poorly controlled asthma or frequent exacerbations may require additional fetal monitoring such as growth ultrasound to assess the potential complications like fetal growth restriction. Whenever this mother is in attacks, we are saying poorly controlled asthma, it means they are having frequent attacks of asthma. It means whenever they are having frequent attacks of asthma, even the baby goes into a state of hypoxia. So it is likely that the baby is also going to face fetal growth restriction. Then, non-stressing tests may be indicated later in pregnancy if asthma is severe, particularly following expirations or in cases of maternal hypoxia. I don't know whether we can do it here, but we said that some of the expirations are caused by stress. So we should be in position to find out what really brings about these asthma attacks. And then, after knowing them, we try as much as possible to avoid them. So, what do we do when we plan for delivery? We are saying vaginal delivery is preferred unless maybe there is an obstetric condition. So, asthma is not an indication to a cesarean section. If there is no any other obstetrical indications like CPD, big babies, abnormal eyes and positions, this mother can ably go through vaginal delivery. So, labor management. So, asthma medication should be controlled during labor. If possible, we can give epidural anesthesia. This is now coming up in Uganda. And that anesthesia, when this mother is given epidural, it means she will have less pain. And remember, the process of labor itself brings about stress. And if this mother, the attacks are exacerbated by stress, it means this mother may go in an asthmatic attack during labor. So we must try as much as possible to control pain by non-pharmacological managements, as you know, talking to them, rubbing the back, change of position, such that this mother is having minimal pain. But if this mother's perception of pain is high, we can go ahead to give some medications, preferably epidural anesthesias. They are saying avoid general anesthesias if this mother is to go for cesarean sections. Regional anesthesia is preferred to avoid airway irritation and complications associated with general anesthesia. So if this patient is to go for anesthesia, let us avoid the general anesthesias, which may irritate, because they may irritate the airway, and in the process of delivery or removing the baby, this patient can go into an asthmatic attack, an airway obstruction. So let us always avoid general anesthesias and let us prefer regional. Then postpartum care, after we have had a successful delivery, successful vaginal delivery or successful cesarean section, then we have a baby. But remember, this is a chronic condition which is not brought about by pregnancy. So asthmatic management should be continued. And most asthmatic medications are safe during breastfeeding, including the beta agonist and the corticosteroids. So before this mother is discharged, we should be in position to monitor the postpartum exacerbations, and asthma symptoms may fluctuate in postpartum period, so patients should continue regular follow-up with their healthcare provider. So those are the key nursing intervention we can do to this mother during pregnancy with a positive history of asthma.